We've all seen those alarming headlines, right? A novel virus surfaces, a mysterious cluster of illnesses emerges out of nowhere, or suddenly an unexpected outbreak shuts down an entire city. It can feel completely chaotic. But how do public health experts actually cut through all that noise to figure out exactly what's happening? Well, they do it by treating diseases as our adversaries and epidemiologists as high-stakes medical detectives. So in this explainer, we're going to decode the exact methods these experts use to track, understand, and ultimately stop public health threats.
Think of this as your official detective briefing folder. We're going to cover 4 key areas today: the anatomy of an outbreak, the 4 stages of disease, how infectious diseases transmit, and finally, the step-by-step protocol for investigating a disease outbreak. Let's get right to work. Section 1. The anatomy of an outbreak. Setting the stage for the medical detective.
Okay, to solve any crime, we first have to profile our suspect. Because from a population-level perspective, a novel infectious disease outbreak is never just a random biological coincidence. There's a precise structure to it rooted in this foundational concept, the epidemiological triad. This brilliantly illustrates the rules of the game. For an outbreak to actually ignite, you need 3 specific elements to perfectly align. First, the agent. That's the pathogen, like a virus or bacteria. Second, the host, the susceptible human or animal that can get sick. And third, the environment, the external conditions that bring the agent and host together. Break just one of these connecting lines, and the outbreak completely stops.
So, how does this triad actually spark a real-world crisis? Well, it usually starts with a zoonotic spillover, where a virus jumps from its natural wildlife reservoir into a human, our index case. But the virus only survives if it finds host susceptibility. If a community has absolutely no prior immunity, the pathogen spreads like wildfire because the herd immunity threshold just isn't there. Next, we have environmental facilitation, things like severe overcrowding or poorly engineered ventilation systems that act as massive catalysts. And when all these things align, you get a super spreading event. This is where a single highly infectious individual in a dense social network transmits the disease to a disproportionately massive cluster of people, turning a slow spread into an explosive outbreak. A classic, tragic example of this is the November 2002 SARS outbreak in Foshan, China, which ignited in a crowded live wildlife market and quickly accelerated through these exact mechanisms.
Section 2. The 4 stages of disease. Tracking the biological journey. Now that the agent has successfully entered the host, it builds a very predictable timeline of illness within the human body. Every single disease follows this natural history. It starts at day 0, the stage of susceptibility, literally the exact moment of exposure. Next comes the incubation period, or the stage of subclinical disease. Now at this point, the patient feels perfectly fine, but beneath the surface, the pathogen is multiplying. This silent window is where secondary prevention, like active screening, is absolutely critical to getting ahead of the curve. Then we hit the inflection point, the stage of clinical disease. Symptoms finally appear, diagnoses are made, and patients seek medical help. And at the very end, we reach the stage of resolution, which unfortunately can mean recovery, chronic disability, or even death. As patients move through those stages, public health experts have to measure the impact on the wider community. And to do that, you have to understand the crucial distinction between incidence and prevalence. Think of incidence like a leaky faucet. It measures the flow of brand new clinical cases developing over time. It tells us our immediate, absolute clinical risk. Prevalence, on the other hand, is the total water already sitting in the sink. It's the static pool of everyone who currently has the disease, old and new cases combined. If you want to know how fast an outbreak is spreading, you look at the incidence faucet. But if you need to know how many hospital beds or long-term care resources you're going to need, you look at the prevalence sink.
Part 3. How infectious diseases transmit. Tracing the pathogen's path.
To actually stop our suspect from filling up that sink, we need to map exactly how it moves from one host to the next out in the real world. Pathogens are basically escape artists, and they typically choose one of 2 main routes. Direct transmission is straightforward person-to-person spread. Think of respiratory droplets from a cough or direct physical contact. Indirect transmission, though, is a bit sneakier. The pathogen uses a middleman, either a common vehicle, like a contaminated water supply or food source, or a vector, like a mosquito carrying a virus.
Let's look back at the 2002 SARS outbreak again to see how this plays out. It began with an index event via direct transmission where a chef in Foshan infected his family. Epidemiologists quickly identified the animal interface, finding identical viral strains in market animals like civets. But then, things got terrifying with nosocomial amplification.
frontline healthcare workers in Gwangju, operating without adequate personal protective equipment, became unwitting vectors. They accounted for a staggering 24% of all regional cases. The virus used both direct community spread and this indirect hospital amplification to achieve multicentric dissemination, rapidly hopping right across municipal borders. Section 4. Investigating a disease outbreak with the 8-step protocol. Armed with an understanding of how diseases work and transmit, it is time to deploy into the field. We use a rigorous 8-step investigation protocol based on Leon Gordis's foundational epidemiological framework. The first half of our investigation is all about descriptive epidemiology, verifying the threat and gathering the raw clues. Step 1 is crucial. We must verify that observed cases actually exceed the expected baseline numbers and establish a strict case definition so we know exactly who to count. In Step 2, we characterize those cases. Step 3 involves cross-tabulating metadata to find variable interactions, like figuring out if eating the egg salad, the tuna, or both caused a foodborne illness. All of this data feeds directly into Step 4, where we formulate a solid, testable hypothesis about where the disease came from and exactly how it's spreading. Now, what's really fascinating is how detectives execute Step 2. They map the person, place, and time to visually reconstruct the crime scene. For person, they look at demographics and attack rates to find highly susceptible profiles. For place, they create GIS spot maps, just like the famous map John Snow used to trace a cholera outbreak to a single water pump in London back in the 1800s. And for time, they draw an epidemic curve. The shape of this curve tells them instantly if they are dealing with a single-source explosive event or a prolonged person-to-person spread. Once we have our clues, the second half of the protocol shifts from observation to definitive action. In Step 5, we rigorously test our theories using statistics. Then comes the most critical moment, Step 6. This is where lives are saved by implementing immediate control and prevention measures. After the immediate threat is handled, Step 7 involves meticulously documenting everything in a formal written report. And finally, in Step 8, we communicate those findings transparently to public health stakeholders and policymakers, ensuring we actually prevent future disasters. Let's zoom in on Step 5 for just a second. To mathematically prove our hypothesis, we generally choose between two analytical study designs. A case control study looks backward. We take 6 people, our cases, and healthy people, our controls, and look back in time to calculate the odds ratio of their past exposures. It is incredibly fast and ideal for acute, highly fatal, novel outbreaks. A cohort study, however, looks forward. We take an exposed group and an unexposed group and follow them over time to calculate the relative risk of developing the disease. Once the math confirms the culprit, we launch Step 6, a 3-tiered defense strategy that escalates based on the threat. First, primary prevention stops the disease before it even starts. This means enforcing vector control, isolating the source, and getting PPE out there. But if the pathogen slips through, we move to secondary prevention, catching the disease in its silent subclinical phase using massive screening programs and rigorous contact tracing. Finally, if patients are fully symptomatic, we escalate to tertiary prevention. This is all about specialized clinical management in the hospitals, providing life-saving interventions like hemodialysis for organ failure to minimize permanent disability and drive down that ultimate case fatality rate. And that brings us to the end of our briefing. We've seen how epidemiologists act as true detectives, tracing a pathogen from a single spillover event, mapping it through the stages of human disease, tracking its transmission pathways, and finally shutting it down with a structured 8-step protocol. But as we close this case file, I want to leave you with this final thought. The mechanics of outbreaks are completely predictable, but our readiness is what ultimately decides the outcome. So looking at the highly interconnected world we live in today, are our global surveillance systems truly ready for the next undetected index case? Thanks for joining me on this explainer, and keep asking the right questions.